If you're gearing up for the PBC MCQ exam, you know that Parkinson's disease is one of those topics you've just got to nail down. So in this explainer, we're going to cut right to the chase, focusing on the high-yield info and clinical pearls that you'll actually remember on exam day. Let's get right into it. So here's our game plan. We're going to build this from the ground up, starting with the disease fundamentals and how it's diagnosed. Then we'll talk about treatment goals and dive into the absolute gold standard, levodopa. After that, we'll look at all the other drugs in the toolbox, figure out how to handle the really tough complications, and finally, we'll pull it all together with some super practical algorithms and pearls. First up, the basics. All right, let's lay a solid foundation here. Before we can even begin to talk about treatment, we need to be absolutely crystal clear on what Parkinson's actually is and how it presents in a patient. At its very core, Parkinson's is a dopamine problem. Simple as that. Deep inside the brain, in an area called the substantia nigra, the specific cells responsible for making dopamine are slowly and progressively lost. It's this growing deficit of dopamine that directly causes all those classic motor symptoms we associate with the disease. Now, we all know the big three motor symptoms, right? The tremor, the slowness, the rigidity. But here is an absolutely critical point, not just for your exam, but for your practice. It's the non-motor symptoms that often become the biggest challenge. As Parkinson's progresses, things like cognitive decline, depression, and all sorts of autonomic issues can honestly become way more disabling for a patient than their tremor. So how do we diagnose it? Well, there's no fancy blood test or brain scan. It's a clinical diagnosis, meaning it's all about recognizing that classic pattern of symptoms. And here's a massive clinical pearl for you. One of the best ways to confirm the diagnosis is to see if the patient gets better on a trial of levodopa. If they respond well, you can be much more confident you're on the right track. Knowing what Parkinson's isn't is just as important as knowing what it is. These right here are the major red flags. If you see a patient with severe balance problems right from the get-go, or if they just don't respond to levodopa, you've got to start questioning the diagnosis. It might be what we call an atypical Parkinsonism, and that's a whole different ballgame. And of course, we have to play detective and rule out other causes. Now, something like Wilson disease is rare and mostly for younger patients, but the big one, the one you as a pharmacist absolutely have to know, is drug-induced Parkinsonism. You have to scrutinize that medication list for any dopamine blockers like antipsychotics or even common anti-nausea meds like metoclopramide. Okay, now that we've got the diagnosis figured out, let's switch gears and talk strategy. What are we actually trying to achieve here? And what can we do for our patients before we even write a single prescription? The goals are pretty straightforward, but they're incredibly important. Look, we're not aiming for a cure, unfortunately. The real goal is to improve day-to-day function and quality of life, to be super mindful of the side effects from these powerful drugs, and, just as importantly, to help our patients maintain a positive outlook while living with a chronic disease. Before we even touch pharmacology, this is ground zero. And I want to be really clear, exercise is not just a nice to have, it is an absolutely critical part of the treatment plan. The evidence is overwhelming that it reduces falls, dials down symptom severity, and gives a huge boost to quality of life. As pharmacists, we need to be huge advocates for this and for getting the whole healthcare team, physio, OT, speech, involved. But what about when the disease progresses and the medications just aren't cutting it anymore for those motor symptoms? Well, that's when we start thinking about more advanced options, like deep brain stimulation or DBS. Now, DBS isn't for just anyone. The ideal candidate is usually a bit younger, with really troublesome motor symptoms, but whose thinking and memory are still in good shape. And managing expectations is so important here. DBS is not a cure. The best way to think about it is that it helps get a patient back to their best on time, how they felt when their medications were working perfectly. It's also important to note that it usually doesn't do much for balance problems. Okay, it's time for the main event in Parkinson's pharmacology, levodopa. Make no mistake, this is, without a doubt, the gold standard treatment. The way it works is actually pretty brilliant. Levodopa is a building block for dopamine that's able to sneak across the blood-brain barrier. But here's the trick. We have to give it with a bodyguard like carbidopa. Carbidopa can't get into the brain, but it stops levodopa from being converted into dopamine everywhere else in the body. This means more gets to the brain where we need it, and it massively cuts down on side effects like nausea. This is a huge point, and it's a major shift from how things used to be done. The old idea of saving levodopa for as long as possible, that's totally outdated. Today's guidelines are very clear. If a patient's motor symptoms are getting in the way of their life, levodopa is our most effective tool, and there is no good reason to delay starting it. But, and this is probably the single biggest challenge in managing Parkinson's long-term, levodopa therapy comes with a major catch. After about 5 years of treatment, almost half of all patients will start to develop motor complications. We're talking about fluctuations in their response and the appearance of these involuntary movements called dyskinesias. It's so important to know the different flavors of these complications. Wearing off is exactly what it sounds like. The benefit from one dose just doesn't last until the next one is due. Dyskinesias, on the other hand, are those extra, involuntary, often dance-like movements, and they can show up at the peak of a dose, at the beginning and end of a dose cycle, or even as painful muscle cramps when the medication levels are low. Recognizing these is the first step to fixing them. So why does this happen? Well, the leading theory gets right to the heart of the problem. You see, a healthy brain gets a nice, steady, continuous supply of dopamine. But levodopa therapy creates these big peaks and troughs. It's this pulsatile or up and down stimulation of the dopamine receptors that we think drives these long-term motor problems. So, if levodopa is so effective but has this major long-term issue, what else is in our arsenal? Let's do a quick run-through of the other major drug classes, focusing on the key things you're going to need to know for the exam. First up, the dopamine agonists. These drugs skip the middleman and directly stimulate the dopamine receptors themselves. We can use them alone in early disease or add them onto levodopa later. Just take a look at the side effect profile for pramipexole and ropinirole. Notice how similar they are? You'll definitely want to commit those to memory. Okay, here it is, your big, bright, flashing red lights exam alert. The side effects of dopamine agonists are classic test questions. You absolutely, positively must know about the risk of impulse control disorders. We're talking about things like pathologic gambling, hypersexuality, compulsive shopping. It can happen in up to half of all patients. And on top of that, there's the risk of sudden, overwhelming sleep attacks. These are massive counseling points. Next up, the MAOB inhibitors. These guys work by preventing the breakdown of dopamine in the brain. Selegiline gives a mild benefit, and a key pearl is that its metabolites are kind of like amphetamines, so you want to give it in the morning to avoid insomnia. Rasogiline is a bit more potent and can be used early on or to help with wearing off. And then there's safrinamide, which is only used as an add-on for wearing off. And here is another absolutely critical safety warning. Because these drugs inhibit monoamine oxidase, there is a serious risk of serotonin syndrome if you combine them with other serotonergic drugs. So you have to be incredibly careful with SSRIs, SNRIs, tricyclic antidepressants, and even things like mepridine or the dextromethorphan and cough syrup. This is a classic drug interaction question for sure. The COMT inhibitor entacapone is another helper drug for levodopa. It blocks a different enzyme in the body that breaks down levodopa, basically making each dose last longer. So the most important thing to remember is this. It does absolutely nothing on its own. It has to be taken with levodopa. The side effects are pretty much just more of levodopa's effects, and you should always tell patients to expect a harmless orange-brown color in their urine. Now, amantadine has a very specific, very important job. It is not for general motor symptoms like tremor or rigidity. Its primary, #1 use is to treat the levodopa-induced dyskinesias that we see in the later stages of the disease. A classic side effect you need to know is levodoreticularis, that lacy, purplish pattern on the skin of the legs. And finally, just a quick word on anticholinergics like benztropine. Honestly, their role is extremely limited these days. Maybe, just maybe, for tremor in a very young patient. But in general, we avoid them like the plague, especially in older adults, because of their heavy side effect burden. Confusion, dry mouth, constipation, you name it. So, we've got our list of drugs. Now let's get into the really tricky part. How do we actually use them to manage some of the toughest challenges in Parkinson's, like all those non-motor symptoms and the complications of advanced disease? Let's start with a really common and difficult one, psychosis, especially hallucinations. How do we approach this problem in a smart, systematic way? The approach absolutely has to be stepwise. First things first, rule out any other medical cause like a simple urinary tract infection. Second, look at all the patient's medications. Third, and this is so key, try to reduce or stop the Parkinson's drugs in a specific order. You start with the least important ones like anticholinergics, and you only touch levodopa as an absolute last resort. Only after you've done all that do you even think about adding an antipsychotic. And when you do need an antipsychotic, you really only have two good choices. Quetiapine is often tried first just because it's easier, no blood monitoring needed. But the clinical data for it is kind of shaky. Clozapine, on the other hand, has clear evidence that it works and it has the lowest risk of making motor symptoms worse. But it comes with that major headache of regular blood monitoring. And the most important note here, all other antipsychotics are a no-go. They will make Parkinsonism worse. This table is your cheat sheet for other common non-motor problems. For dementia, you can use cholinesterase inhibitors like rivastigmine. For that lightheadedness from orthostatic hypotension, always start with non-drug approaches before trying things like domperidone. For constipation, it's lifestyle first, then laxatives. And for that very common issue where patients act out their dreams, REM sleep behavior disorder, clonazepam or melatonin are your go-to options. All right, let's bring this all home. We're going to put everything we've talked about together into some practical algorithms and high-yield tips that are absolutely perfect for your exam prep. Okay, let's walk through this algorithm for starting treatment. The very first question you ask is there functional impairment? If the answer is no, you can just observe. If it's yes, but the symptoms are mild, an MAO-B inhibitor is a reasonable place to start. But if the impairment is significant, you hit a key decision point. Traditionally, for a younger patient, you might start a dopamine agonist to try and delay needing levodopa. For an older patient, you'd go straight for levodopa. That thinking is starting to change, but it's important to understand this classic approach. Now let's look at the more advanced stage. This algorithm for managing motor complications is pure gold. Notice the two main paths at the top. Is the problem wearing off, or is it dyskinesia? If it's wearing off, you look to the left. The strategy is to extend levodopa's effect, so you might increase the dosing frequency or add on a helper drug like entacapone. But if the main problem is too much movement, dyskinesia, you follow the path to the right. Here, the strategy is completely different. You might add amantadine, or you might even decrease the levodopa dose. These are the kind of practical tips that separate the good from the great. Number 1, always start low and go slow, especially in older patients. Domperidone can be a really useful tool for just the first few weeks to get patients over that initial hump of nausea. And the advice for levodopa and food is tricky. At first, take it with food to reduce nausea. But later on, in advanced disease, you actually have to separate it from protein because the protein can interfere with its absorption. And finally, here are 3 critical warnings you need to have locked down for your exam. 1, never ever abruptly stop dopaminergic drugs. It can cause a life-threatening reaction called Parkinsonism hyperpyrexia syndrome. 2, remember that incredibly high risk of impulse control disorders with dopamine agonists. And 3, be aware of the cardiac risk with domperidone, especially in patients who already have heart problems. You know, all these strategies and warnings really bring us back to the central challenge in treating Parkinson's. It's this constant balancing act. How do we provide powerful relief from symptoms today without causing debilitating complications down the road? Figuring out better ways to walk that tightrope is really the future of Parkinson's care. Thanks so much for tuning in, and I wish you the best of luck on your exam.